Maybe you have been diagnosed with endometriosis. I'm sorry to hear that. It can be a scary diagnosis to get. And when we look at the conventional models for treating this, there's not much great stuff out there. So I wanted to make a video for you on what I see as the treatment regimen that allows most of my patients who come to me with endometriosis to end up living with less than 2 out of 10 pain. Now, this is going to be a little bit of a long video because I want to cover a lot of things. And so sit tight, grab a little cup of coffee or tea, and let's talk. My name is Nari Clemons. I'm a certified pelvic rehab specialist and a national educator. And one of the things I educate on is endometriosis. My practice is a little unusual in that I see a lot of endometriosis patients in my clinic because it's actually my favorite thing to treat, which is something that not many people like to treat because it can be difficult. So I made another video on what are the warning signs of endometriosis, and check that out if you're wondering if you have endo. This video is more geared for people who know they have endo or who are highly suspicious of it. Now, one thing I covered in some of the other videos is what is endometriosis? It's endometrial cells that should be inside the uterus that are outside the uterus. And so those are growing and multiplying. Now, there's two different kinds of endometriosis. One kind of endometriosis tends to be around the ovaries, and sometimes it's around the outside of the uterus. And that is what most conventional surgeries for endometriosis, like any OB could go inside and do a lap, and they would just kind of burn away some of the implants they find. And that is what a traditional lap for endometriosis is. The other thing is that is how often people are getting the diagnosis, is when somebody gets in and sees it. Now, when we look at the studies that the American Society of Reproductive Medicine puts out, or even the position statements of ACOG, the American College of Gynecology, these organizations flat out admit that the surgeries help with pain in the short run at best. And within a year, people often have as many adhesions as they had prior to surgery because they're getting adhesions from the surgery itself. And so a lot of patients end up on this repeated surgery wheel, and it never really gets rid of it. There's a different kind of surgery that is also being done, and there are only a certain number of specialists for this in the country. This type of surgery is called excision surgery. So ablation is where they go in and just burn what they see in the front. Excision is a very skilled surgeon who goes in and checks everywhere. They get deep in the small intestine. They look all around in there to find every last implant. They're checking along the sides of the abdominal walls to clear that out. They're going behind your uterus and looking between the uterus and the rectum. That space is called the cul-de-sac of Douglas or the recto-uterine pouch. That is one of the really common sites of endometriosis. And when it's there, it often will also be on the uterosacral ligaments. So those are the ligaments that attach the uterus all the way back to the sacrum. So if somebody is just looking in the front of the abdomen, they're not going to see any of that. Also, a number of patients who have endometriosis have insane back pain. It's terrible back pain. It's not like, oh, I worked out and I'm a little sore. No, it's a different kind of back pain because the kidneys are in a space behind all the organs. There's a pouch called the peritoneum, and all the organs live in that. Most of them do. Parts of the small intestine, the duodenum, are behind that, but the kidneys also live behind that pouch. They actually live on the back side of your body. It's called the retroperitoneal area. But how the urine from the kidneys gets all the way to the bladder is it goes down a tube called the ureter that goes from the back of the body, pierces through that peritoneum, and goes into the bladder in the front of the body. In some patients, endometriosis will start to grow up that tube and into the ureter toward the back where the kidneys are. And a lot of the nerves from the low back, called the lumbar plexus, are all around the kidney, coming around the backside of the psoas there, and so the endo can start to impinge on those nerves. So a very good excision surgeon is going deep in the abdomen and checking all the way in the back for it. Now, why have you maybe not heard of this? It's a coding issue. So the American College of Gynecology hasn't fought for a separate code, a separate billing code for excision, which those surgeries can take up to 6 hours because they are going and finding every bit of that endometriosis to take it out for you. Versus ablation, which is just burning what's in the very front of the abdomen. So one of the things I think is important is, as part of this whole plan of healing, anybody with severe endometriosis is probably going to need an excision surgery at some point to get a lot of that endo out. Now, that's not the only thing we're going to do to treat it, but no therapy, no physical therapy, no diet is going to stop and get rid of the process of endometrial growth. And I'm a very holistic therapist. I'm always like, can we find a supplement? Can we find a little tweak? Can we do a little something to work holistically with your body? But my loved ones, my relatives, my patients who I highly suspect endo, we're talking about, should they be getting an excision surgery? And there are things you can do to prepare for that. But there is a Facebook group called Nancy's Nook Endometriosis Education. It's a private group. You have to ask to be invited to the group. They do have rules around the group. But that is where a lot of patients who have had excision and who are on this healing path share their experiences of the surgeons who helped them. How did they deal with the funding? How did they do after the surgery? And so this is a really great grassroots community to get connected with if you're suspicious that you have endometriosis. So after the surgery, one of the things I like patients to do is take a supplement called Serrapeptase. There are enzymes that you can take that help you to digest food. And then there are enzymes that you take on an empty stomach that actually help decrease inflammation in the body. And Serrapeptase, there's a lot of research on it. I have a separate video on this for you, so you can search under my channel for Serrapeptase. Serrapeptase is the enzyme that silkworms use to dissolve their cocoon. And it actually helps soften, it acts like a little Pac-Man inside the body, softening some of those adhesions. I find after surgery, or even if someone's trying to buy time until surgery, when we combine that with a very specific type of manual therapy I'm going to talk to you about, called visceral manipulation, those two together I feel are very helpful for not allowing adhesions to form in the year after surgery. When we look at the top 11 surgeries that are performed in the US every year, 6 of them are abdominal surgeries. But the 12th most common surgery performed in the US every year is surgery to remove the adhesions from prior surgeries. And you form the most adhesions in the 1 year following surgery. So if you're taking Serrapeptase, again, watch the other videos I've made on how to take it and what it is and all the things. That's going to stop your body from forming adhesions after surgery. I actually can physically feel the difference because I do so much organ work with my clients. I can physically feel the difference between if somebody's on it and off it. I can tell when my patients have gotten up to a therapeutic dose because I can create so much more movement in the abdomen with my manual therapy. And every once in a while I'll have a patient and my deal is I will help you through endo, but you probably need to work with a doctor and get on this supplement. And I can tell when people go off of it because they'll be doing great and all of a sudden their abdomen will feel sticky again. And I'll just say, did you get off your Serrapeptase? And inevitably the person will say, oh my gosh, I ran out of it and I forgot to order more because I was feeling so good. So this is a really helpful thing. And another very helpful tool can be a different medication called low dose naltrexone. And I'll have a separate video on that. I'm not a doctor, so I can't tell you to take a medicine, but I will have another video that describes what I know about it so you can have an informed decision and discussion with your own physician. The third thing that I find to be really helpful is for someone to get visceral manipulation therapy. In fact, I don't really recommend people get excision unless they have a physical therapist who practices visceral manipulation, who can help them in the year after surgery. I highly recommend people get manual therapy twice a month for the first 6 months after surgery, and maybe even from 6 weeks to 12 weeks if they can afford to get therapy weekly during that time, and then once a month for the next year. So it's a commitment that I like my patients to make weekly from week 6 to 12, and then twice a month from week 12, which is basically like the 3-month mark, to the 1 year mark, getting therapy twice a month during that time. And then in the second year after surgery, just once a month. Now, not just any pelvic therapy. I have a different video on my channel about why traditional pelvic therapy does not help endometriosis. But with visceral manipulation, you can have your therapist work on the movement between the bladder and the uterus, between the bladder and the pubic bone, between the uterus and the rectum. They can work on treating all along the fallopian tubes, mobilizing the fascia around the kidney, mobilizing the fascia along your iliac crest. Adhesions love to form where there's not movement, and it's not that easy to move your own organs. I'm a visceral practitioner and I can't even do it well to myself. Now, this therapy does not hurt. It does not need to hurt. It can be done gently, but you want to find someone who has a lot of specific training in visceral manipulation to get you through that year after. Herman Wallace, one of the companies I teach for, they do offer visceral manipulation classes. So they could probably help you out with finding someone in your area that's taken a lot of the visceral courses. That's hermanwallace.com. There's a site, pelvicrehab.com, that can list that. And then there's also a company called the Barral Institute, Barral Institute, that does also teach visceral manipulation. And so if you can't find a pelvic therapist in your area, you might be able to find a massage therapist in your area, but who does that. But it's really good if someone can do internal work and external visceral work for you. That is going to help so much in the year of recovery. And then the last part I would say is having a lower inflammation diet can help in the recovery year for endometriosis, and then moving your abdomen can help. But I actually find that even when somebody comes into me with very severe endometriosis pain, 9 out of 10 pain, 8 out of 10 pain, if we can get them with a very skilled excision surgeon and have them follow this protocol, it is my expectation that those patients will be living with less than 2 out of 10 pain by 1 year. It's not a 2-visit fix. I have people all the time who ask me if they can fly in from out of town to see me, and the answer is yes. But if you haven't had a surgery or anything and you think that coming into town for 3 days and doing an intensive with me, or with anyone who's doing manual therapy, an intensive of manual therapy to clear out all of this, it just doesn't do it for endometriosis because there's still an ongoing disease process. Something that helps a lot of people who are still in their reproductive years is sometimes getting an IUD or something that can keep their hormones more stable in the local environment. Now, just taking birth control can sometimes, if someone's on continual birth control, some of endo is hormonally mediated, those endometrial cells that got outside of the area. But then the adhesions that are outside of the area don't have anything to do with hormones. And so whereas birth control can sometimes buy us time where the disease isn't progressing, or sometimes when we have a really young patient who might be 16 or 17, some of the excision surgeons say, like, wait a while, because we want to be able to see every place where the disease is and clear it. And sometimes when people are young, you can't find it. And so for, again, my patients, my friends who are young, if they're not ready to have the surgery, sometimes an IUD can buy time, where at least it doesn't help with the irritable bowel syndromes and all that, but at least their periods might be a lot less painful, and it might control the rate of disease progress. The minute you go off the birth control, the symptoms come back. It was kind of old school in the past to put women in a state of total hormone suppression, basically to put them in medical menopause to help. But the problem is that menopause, there's bone density issues that come up, and there's just a lot of issues. There's mood issues. We hear this a lot now about menopause and perimenopause, and even people who are in those states tend to like a bit of hormone replacement therapy to help them feel better. And then also you would have to use vaginal estrogen so that you don't end up with pelvic floor weakness or pelvic floor dryness. So the idea of suppressive therapies that put someone in a menopause state, that's kind of outdated treatment now. The idea is maybe that could buy time until something else can be done. Now, one of the questions people have all the time is, why are more surgeons not doing excision? And the problem is ACOG and ASRM, these leading governing bodies for gynecologists, haven't fought for a separate billing code for excision, which can be a 6-hour surgery, or a lap, which can be a 45-minute procedure. And so what happens is these incredibly skilled surgeons who have gone and done all this extra training, often in the traditional insurance model, they just can't get reimbursed for the amount of time they're paying. They wouldn't even be breaking even. And so sometimes if you know you're going to have this surgery, I'll make a separate video on preparing for your year of surgery, and we'll talk about some things to keep in mind. But those are just some things to keep in mind about how can endo be treated and treated well. And if you want to keep collecting more information or to learn more about different supplements, different things that can help, different comorbidities, you can just hit that follow button and I'll try to keep making videos. And if there's a video that you want, a certain topic, just drop me a message and I'll try to make one for you on that. Thanks.